Welcome back, everyone, to the Research Works podcast, a very special edition as we're in EACD in Slovenia 2023. So now I have a wonderful poster to talk to you guys all about. It's a great poster. I feel like it's something everyone needs to know about. So our guest today is Dr. Nathalie De Beukelaer from KU-Leuven and University of Geneva. Welcome.
Thank you. Thank you for the invitation. And pleasure to talk about our poster with you.
Oh, it's lovely. So much work goes into a poster. Every time I look at someone's poster and I see a graph, having done many graphs before, it represents maybe 10,000 hours before you can put up one graph to show the result. And there's so much to it. But the topic we want to talk about today really caught my eyes because it's about morphological muscle growth in infants and toddlers, a longitudinal study. And this is part of your PhD.
Yes, it was indeed. Yeah.
Oh, fabulous, fabulous. Yeah. So let's start back with why you decided to go into this area. What drew you into this area of muscle morphology?
Yes, so I was always fascinated by seeing babies and infants moving around.
Yeah.
And then I realized, okay, I did physical therapy, and what do you need for your movements? You need your muscles. They
Yes.
provide the force of moving.
Yep.
So I was always wondering, like, okay, how do they look? And how can we measure how they grow over time? Because they probably need them in their growth of also their anthropometric measures like body weight and body length. So I was a bit, my curiosity, like how do they grow? And especially how do they grow over time? So that's also why we did a longitudinal study.
I love that. That's great.
And in our team, we had already expertise by using a 3 different ultrasound technique.
Yes.
Which, so normally children need to go to the MRI, but we found a way to do it in the hospital. It's portable, it's cheap, and the children love it because you put some ultrasound gel on their body. It's like a massage.
Yes.
So all the infants were like very relaxed by doing these measurements.
That's great.
So we also found that it's feasible to do these
great
observations of muscles.
So it sounds like your team was just ready to go. Like you had a really nice team that had all these skill sets.
Yes, we had, but not on infants. So I was the first in our team.
Well done.
Because I also had some experience at the neonatology unit, so I was able to handle this position and so because it's not like an older infant, so you should be a bit more expertise in handling.
It's very specific.
And how to calm them down and get some distraction with some toys or movies or songs.
Yeah. I know, there's no shortage of knowing all your nursery rhymes, right? So I love how you described how you came into this area. So you're interested in muscles, you've got a background working with infants and neonatology unit, you've got this great team now. So let's talk about this really specific study because I think for me, when I know the results of it, which we'll talk about towards the end, it's so significant for so many of us working with children. So tell us a bit about the population. Who were the kids that you were really investigating for this particular study?
So we tried to start from the age of 6 months.
Okay.
So very young.
Very young.
But we want also to have the time that they're already moving so that they use the muscles up to the age of 3 years.
Okay.
So we focused on really young children, but in a phase that they're developing a lot.
Yes.
So we had the idea we should do it in a longitudinal study.
Such a good
with,
idea.
An interval of 6 months, because then we know like the development could already progress over 6 months. So we should have multiple assessments per child. That was our idea.
Yep.
And then we want to try to understand what is the neurotypical developing of a muscle. So we also included these type of children or this population comparison to then the children with a high risk for or already the diagnosis of spastic cerebral palsy.
Right. Okay.
So that was our target group.
Yep. So this target group, so it was spastic cerebral palsy, so it could have been either a unilateral or a bilateral. And I imagine at 6 months, not every child would have been diagnosed with cerebral palsy yet.
No. So we started that they should have a brain lesion conferred on MRI or ultrasound imaging so that we have a kind of clinical sign or history that could make them suspected for this diagnosis.
So the high risk group too.
Yes, especially the highest risk. Yeah, some of them are also prematurely born.
Sure.
But some of them could also have an injury of the brain at the time that they were a term born.
So that's quite unique then, the fact that you did include children at high risk as well as already a diagnosis of cerebral palsy.
It's needed to do it like that because we know that the diagnoses are mostly confirmed at a later age because then symptoms are more present. Yep. So we realized that we should need this at high risk diagnosis to include them. But we had also children who in the end did not have diagnosis, so we excluded them for the final analysis.
Okay.
So we had a large inclusion in the beginning, but
Yep.
then we had also, luckily for the children, had a dropout because they had a normal, or they go into normal development.
Yeah, that's great. So you did measures longitudinally,
Yes.
so up to the age of 3 years?
Yes. Yeah.
But the measures are done every 6 months?
Yeah.
Wow,
Yeah,
that's a lot of
tried.
measurements.
Yeah.
Wonderful. So how many children were part of this study?
So we, in the end, ended up with 20 children with the typical development and 24 children in the end with like the confirmed diagnosis of CP. So that was
That's quite a decent number for the study and for a longitudinal follow-up to keep all that
we
too.
had up to 130 measurements that we included in the final analysis. So we had more measurements, but it was in our final analysis.
That's great. And so your target muscle that you did the 3D muscle ultrasound for, what was that?
From the medial gastrocnemius
medial gastro. And why do we choose medial gastroc? I think that's always an important point to bring up.
So in the clinical picture of CP, we often see that I have more issues at the level of this muscle. It's also much approachable by ultrasound because it's a superficial muscle, so we can observe that clearly with the ultrasound.
They're quite clear borders that you can see through the ultrasound?
I can see them more clearly than, for example, the soleus muscle. It's also very important for these children, but it's more deeper muscle, so it's the quality of your ultrasound should be high enough. So that was, the reasons that we... And it's also often target for a muscle that should need treatment at a later age, so that's also important to know before they even receive treatment that we measure this muscle.
Because a common treatment would be botulinum toxin type A, right? And sometimes you have muscle lengthening too. So it does go through a lot of change.
Lower leg casts,
of course,
these things, or orthoses that they will wear. So it was all before these type of treatments.
Okay, so all of these children who went the ultrasound, none of them went on to use, like they weren't using ankle foot orthoses yet?
Not yet.
No one had Botox?
Some of them maybe in the latest measurements, but not at the beginning, and none of them had botulinum toxin injection. So it's really the
very clean
growth. I don't know if it's
so
appropriate to say,
but it gives us a really good idea about what the natural development would be.
That was really the aim of this study.
Okay, so now that we've teased it out, let's finally get to the results. I can't wait to talk about the results. But it's good to go through the background to appreciate the results. So tell me now about your main result. What was the main finding?
The main finding was if you look to muscle size expressed with a muscle volume or a cross-sectional area in mid-belly, then we found that at the age of 12 months, children with CP has a lower muscle size in compared to typical developing children. And we're confirming actually the literature because it's described already, but it was only described with cross-sectional data sets, so a lot of children with only one measurement, but by combining this with longitudinal data, we could observe the same observation.
Right, so it's really consistent. And do we know how much smaller it is compared to typical development? Was that part of a measure, or is it you can just tell overall statistically?
Well, it's 40%, up to 40% smaller.
40% smaller by 12 months.
Yeah, so it's actually like, I think, if I remember correctly, it's like 5 milliliters in children with cerebral palsy and up to 8 to 9 milliliters for... So
that says a lot, doesn't it? If it's already smaller, this is in the absence of any intervention. This is in a group of children who, I think we sort of talked about them being more classified GMFCS level 1 to 2 and 3. So they're more likely to be active.
Yes,
So, but they're already exhibiting that much of a deficit by 12 months. What are you hypothesizing the reasons for that are? Because that's quite a big difference.
And I need to add maybe additionally that we also look to growth after this age of 12 months. And what we then observed is that their growth rates, so the increase in muscle volume with their increasing age, is similarly. So we observed that they start lower, but then they progress in the same rate, except for the children with the highest GMSS levels. So if you visualize this, you see like parallel lines. Except for the children with a higher GMSS level, they actually
GMSS level 3.
They actually have a lower muscle growth rate. So already at these youngest ages, they don't have the same rate of growth. So one of our hypotheses is that's related to their brain injury.
Okay, of course.
Maybe the earlier the lesion, the earlier the processes of damages to muscle innervation, muscle growth, but also the way of moving or the amount of moving, how much they activate the muscle could also have an influence on how much the muscle is able to grow,
Sure.
or you have these stimuli to grow, like mechanical loading.
Yep.
Could
For sure.
be an issue of, or could be what you need for having this muscle growth.
Yeah. And I guess when you're thinking about the cortical spinal tracts, because this is spasticity, right? So we are talking about the input, the feedback.
Yeah.
Therefore, it's interesting that the GMS level 3s were growing at a slower rate, which makes sense of what you're just saying in terms of the lesion.
Yeah.
But GMS, what I find interesting is GMS level 1 and 2, they were still developing at a pretty good rate. They just started smaller.
Yeah. So that's why we think that early intervention should target this, because they probably start from a lower level and they're up to a growth rate similarly as their typically developing peers. But I know from another study that we performed when we did a longer follow-up that at a certain point this will also be there will be a break point.
Sure.
And after that they will decrease in their muscle growth rates. So we should have the optimal condition, or try to have them at these youngest ages in an optimal condition.
Start them well.
Because we know at a later age the spasticity will be increasing, because we observed in our youngest children that spasticity is probably not the most important impairment at these youngest ages, but it will come at a later age. So we should try to have this muscle in an optimal condition.
Yeah, that's good. It's just another reason why early intervention is so important. So what would your take home be for clinicians? If we, as therapists, are working with these children, we have the opportunity to work with them very early on, what should we be doing?
Don't forget to move with this child. Also with the GMSS ones, it's important that they reach their motor milestones, but try to involve this muscle growth. And what we also have as a hypothesis is that nutrition could be an important influence on this muscle growth. So that this should also be follow up from the very young ages, like how is the eating behavior? Is it feasible? Do they have maybe need more proteins, for example, that could stimulate this muscle growth?
I think that's often a part that doesn't get thought of as much, because potentially a lot of these parents and therapists are so focused on motor development at that time that, other aspects like sleep, we grow when we sleep and our nutrition and well-being is all very important. So it's a very holistic approach, even when we're talking about a muscle. And I like how it's a great call for clinicians to go, okay, the way muscles grow is we need to load the muscle. So we need them to weight bear, we need them to safely be able to put weight through so that they can stimulate growth.
And that's I think a bit also discussion in which type of intervention do we need, because walking is not it's not appropriate for an age of 2 or 3. So but what if we don't let them have the experience of weight bearing, as you said? So it's we're not there. What is the ideal intervention? So maybe via nutrition or growth factors or other type that you can stimulate muscle growth in relation to their normal or the motor developmental milestones that are more age appropriate. So,
and I like how that relates to a talk we did with Ginny Pallig not so long ago, and she was talking about trying to get children to do things on time, because really, though children might be standing, say 10 or 12 months, they're kind of weight bearing and standing in some kind of way earlier on. They're kind of testing it out in a supportive way. They're not fully weight bearing yet, but that does happen naturally. You don't just go from sitting to suddenly standing. There is a process for that. So I like how you said, well, we need to find that intervention, and no, it's not appropriate to be walking yet, but what can we do to find a way to safely start to weight bear? Because I think they spend too much time on the floor. You're not going to get
and
that kind of thing.
We also realize that maybe they don't have all the drive to move. And that's something we should maybe stimulate and could also be sufficient for their muscles.
That's great.
You need your muscle power to go on and explore the world.
That's great. And this is why, research on so many different levels is so important. We can often talk about, what the goal-directed practice is, and, there's all of that, but we do need to understand the structures that we are influencing as well, because that's part of the body. So thank you so much. Congratulations on this body of work. Congratulations on getting everything done for your PhD. That's amazing. And, you know, we're just really grateful we had some time to talk to you today about your lovely poster.
Thank you. Thank you very much for this talk. It was lovely.
Oh,
I enjoyed it as well.
Oh, good. I'm glad. Well, to all of our listeners, remember you can just head to our website, researchworks.net, and we'll put some links there for you so you can refer to some of the work that Nathalie's been doing. But that's all for now, and we'll talk to you guys again with another lovely presenter. So speak to you soon. Bye.